Dr. Jennifer Couper is a pediatric endocrinologist like me. She leads the discipline of pediatrics at the University of Adelaide in South Australia. And she leads the diabetes and endocrinology department at the Women and Children's Hospital, where they provide service to pediatric diabetes clinic, both in a metropolitan and outreach areas, very similar to what we have, about 750 patients, endocrinology clinic of approximately 1,000 additional patients. So really interestingly, she leads the ENDIA Australian Consortium and is a steering member of the Australasian Diabetes Data Network. And she's a member of the International Society of Pediatric and Adolescent Diabetes Advisory Council. And her research work focuses on kind of two main areas in childhood diabetes. The first is the early determinants of childhood diabetes, which I'm going to focus on today. And second is also an area that I'm particularly interested in, which is the prevention of cardiovascular disease in type 1 diabetes. And on a personal note, she's just a delightful person and was kind enough to host me there. I think it was one of the last trips I took before COVID started. So thank you for joining us this morning from far away, Jennifer, and the floor is yours.
Great, thanks very much, Mike, and thank you so much for the invitation. It's a real privilege to be talking for this prestigious institute, and so many of my slides actually were from your people's work, so I took those out first and stuck to some Australian initiatives for this presentation. And just to start, as people come in, this is one of our South Australian beaches, and this is actually the beach where Bill Gates has had quite a few summer holidays when he's come to South Australia. So first I'll be talking about the ENDIA consortium, the environmental determinants of islet autoimmunity, then some screening initiatives that are being set up in Australia, the general population screening pilot and type 1 screen for family members, and an Australian initiated recent onset trial, BANDIT, of the JAK inhibitor, and then a little bit how this is working with our Australasian Diabetes Data Network, and one example of a real world study from that. So all of us who look after children are very aware of the rise of non-communicable diseases, including type 1 diabetes. And the TEDI data has shown, as has other cohorts, this quite striking, very early peak of islet autoimmunity in at-risk children before 2 years of age. And recently, a paper from Richard Oram's group, Exeter in UK, showing that type 1 diabetes does present before 6 months, not just monogenic diabetes, characterised by sort of high genetic risk scores and autoimmunity, and obviously rapid beta cell loss with an association with reduced birth weight, particularly in very young children under 3 months. And the sort of idea that under 6 months was monogenic diabetes, which we'd been taught, I guess, is not completely true. Oh, sorry, I've just gone back on that other one. Slides. So I'll get back. Let's just get to that one. So putting those things together really raises the concept of the developmental origins of type 1 diabetes. We're well aware of the overriding idea of the developmental origins of disease, whereby adaptations prenatally then go on to modify the health of the child and indeed subsequent generations. There have been, both epidemiologically and in cohorts, a lot of prenatal and postnatal initiators considered of islet autoimmunity and progresses from islet autoimmunity to type 1 diabetes and some potential protective factors. But as we know, the findings are discrepant, And even with very large samples, such as provided by the TEDI cohort, effect size is fairly modest. And we're increasingly aware of the heterogeneity of type 1 diabetes, and of course the interactions gene-environment and environment-environment. So with the developmental origins in mind, in 2015 we set up the ENDIA study to follow 1,500 Australian children at risk on account of having a first-degree relative with type 1 diabetes, as much as possible from early to mid-pregnancy, to determine the effect of early life exposures on the development of adult autoimmunity. And as such, ENDIA therefore was the first type 1 diabetes at risk cohort, and proposing that multiple environmental factors in early life will interact via the omics systems to increase penetrance of what we now recognise as being low to moderate risk genes leading to adult autoimmunity.
Jenny?
Yes.
Yeah, I know in the Zoom era, we normally wait to the end to ask
That's
questions.
all right.
But can you go back 2 slides? I want to know what how you define environment interactions. You had that back 2 slides ago.
Yes, sure. I just
What do you think? Okay, how do you do? And I'm sorry to disrupt your flow.
no, it's all right. Well, I guess
environment. What do you think in those mean?
well,
I get gene environment, but
yes, I'm thinking an example would be the recent work with celiac autoimmunity, with interaction potentially between enteroviruses and gluten intake. I think there's been some interactions also between enteroviruses and vitamin D. So, I mean, it may be explained indeed by more gene environment interactions, which we're obviously very aware with things like vitamin D. But I sort of see environment, that type of finding where nutrition and maybe an effective agent seem to be interacting.
so one environmental encounter
One exposure
or practice will set the stage for a second environmental exposure to come in on top.
That's right.
Okay,
Where,
thank you. Appreciate that. Thank you.
So the sampling in India is frequent and in each trimester, if we can. We often only getting the woman in actually in the second trimester or the third trimester, as you can imagine. Then initially 3 monthly for the first 2 years if possible, and then 6 monthly thereafter. We currently sort of have funding to follow through to 5 years, hoping to be able to follow right through to 10 years. And we're looking not just at the mother and child, but also the father and the sibling at home, even if they're not the proband, and have some unique samples, such as the mother's vaginal swab, the colostrum, a cone if we can get it, and lots of breast milk. And the omics sampling is supported by questionnaires. Nutrition, we're particularly, we have it right from pregnancy, but we have a most sensitive look in that second year of life when we're anticipating the serovertical conversions to mainly occur with a 24-hour multi-pass food recall done by 3 dietitians. So that's really where our sort of best nutritional data is going to come. Lifestyle includes infant sleep and pregnancy physical activity, and we also are looking at maternal stress and depression. It's routine now in Australia to postpartum look at this, but we're also looking at it in the 3rd trimester. So our sort of strobe is looking like this. We had about a 55% rate of entry into the study, and follow-up, our dropout rate at present is about 8.2%, and most of that is occurring, like TEDI, I think, in the first sort of 1 to 2 years, particularly due to the load of the study. But what it amounts to now is a sort of an infant population of 1473. And not surprisingly, the slight majority of the probands is the mother, because it's obviously easier to find a pregnant mother than a father of a pregnant mother, but father of the pregnant partner, and siblings with a small family size we anticipate to be the lower proban rate. The children are still quite young, median age of 3.2 years. And of course, unlike Teddy, because we're basing risk on the basis of family history, DRXX is in 25% of this group. And our primary outcome is persistent autoimmunity. And again, we're seeing this early rise in from the end of the first year of life through to the in the first 2 years. Our survival curves are showing, not surprisingly, these very young children are getting through to multiple autoimmunity more quickly than the ones that are staying single. And again, like the other cohorts, it's just under 80% have insulin autoantibodies first, in the lower of the two survival curves there. And of course, we are measuring zinc transporter 8, unlike Teddy. So we do have, as the first antibody, we have a few like that, but it's obviously the least common phenotype we're seeing. And we have a retrospective preconception lifestyle questionnaire. And this is just really to show, like for USA, a substantial number of our mothers and fathers are overweight to obese at conception, with those median BMIs, particularly the fathers actually. In relation to weight, in the preceding cohort, which was small, between Victoria and South Australia, the Australian Baby Diet study, we showed that in the first 2 years, weight Z was related to the development of autoimmunity later, and with quite a hazard ratio of 2.8. And this, as you know, has been shown in much more detail in the Teddy cohort quite recently, with the modelling in 2 distinct growth phases in Teddy, showing that high birth weight and a higher rate of weight gain really in the first 9 months was associated with increased risk of autoimmunity, particularly in the children with the first appearing GAD rather than insulin autoantibody. And then the higher rate of weight gain on the second year of life was associated more with the increased risk of progression from autoimmunity to type 1 diabetes. And likewise for linear growth, length and height in the childhood, increased risk of progression from autoimmunity to type 1 diabetes. So I think some unanswered questions which we hope we can answer in a cohort study in India over the next year or so is, what about the impact of maternal and paternal weight and body mass index, and possibly gestational weight gain on risk of autoimmunity? Gestational weight gain is quite a messy measure, particularly with variation of when you actually get the 2 weights. And there has been some local work in our hospital showing that gestational weight gain is not greatly affected by lifestyle influences during pregnancy. And indeed, women of high BMI tend to have low gestational weight gains. So we're not expecting to see much from that, but we think we're looking to look at maternal and paternal impact. And of course, the potential mechanisms of the impact of infant weight gain on risk of autoimmunity haven't really been resolved, possibly through the gut microbiome. We will be looking at markers of growth and adiposity, but we have non-fasting samples in India, and we can't do Homer index, etc. So we'll probably be using IGF-BP1. Quite interesting in your thoughts about that, Mike, for a marker of insulin resistance. So the early life gut microbiome is led from Len Harrison's laboratory at Walter Knights Hall Institute, as you know well. And while obviously the goal of ENDIA is to look at it in relation to the development of autoimmunity, first their laboratory has looked at pregnancies complicated with maternal type 1 diabetes in comparison of those without, because we will set up to look at that, obviously, with the 60% probans being maternal type 1 diabetes. And the microbiome healthy pregnancy, in some doubt about it. The first landmark paper from Corin suggested that there was a significant change between the first and third trimester gut microbiome in pregnancy, whereby it became pro-inflammatory to the degree when it was transplanted into an experimental model. You got insulin resistance in the mouse model. And these quite dramatic changes were thought to probably be adaptive for the growing fetus. However, others haven't confirmed this, and certainly we have not shown this across the pregnancies in ENDIA. We've shown no change across the trimesters in diversity, both in women with type 1 diabetes, shown in the red, and in women without type 1 diabetes, shown in the blue. But not surprisingly, using metagenomic analysis, this was Alex Schultz's work at WeHi, showing distinct functional changes in the gut microbiota in the pregnancies complicated by type 1 diabetes, whereby there was a decrease in microbiota that produced short-chain fatty acids. And looking on the left at the butyrate synthesis from acetate pathways, so the red is the type 1 diabetes. You can see it's sort of lower across the trimesters, so that's sort of trimester 1, 2, and 3 with the 3 points, and for not type 1 diabetes, it's consistently higher. And then the indirect synthesis of butyrate from lactate showed sort of fall between the trimester 1 and trimester 2 in the woman with type 1 diabetes, but quite marked differences from the woman without type 1 diabetes. And another another question that we hope ENDIA might be able to answer for us is, does the mother's gut microbiome condition hurt the innate immunity in her offspring? Because in utero, the infant's exposed to the mother's gut microbiome, products of which will condition the baby's innate immune system and its response to pathogens, including potentially some that might trigger type 1 diabetes in very early life. And, I think we still don't completely understand why mothers confer a lower risk to the child than fathers, and possibly the difference in the microbiome of the mother with type 1 diabetes might give some clues to this.
So, Jenny, can I interrupt again? And I wouldn't interrupt if I weren't interested. This is fascinating.
That's good.
Are you saying that you feel like it's chronic? It might be a chronic situation with the mother that is influencing risk for diabetes in the offspring, or are you saying it might be an acute event in the mother that's influencing risk in the offspring?
Well, I think it's hard to know. The idea. I mean, we don't think we quite know exactly from when the mother's gut microbiome may influence the child, and indeed whether it's all primarily at birth and postnatally, or whether there's a prenatal influence. But you would expect that the biggest influence was around the time of birth. But I don't think we know. And I think this is something that we do have the samples to look at, because we do have quite a lot of sampling around just prenatally, cord blood, and postnatally. Oh, sorry. I've got a very sensitive mouse here. That's a new computer that I'm... I'll just... And this is a much smaller cohort, the TIGS cohort, type 1 diabetes in the gut in Australia. which was primarily in South Australia, really, but just really showing that our children are behaving, not surprisingly, like the Northern Hemisphere children. So the children with autoimmunity and type 1 diabetes had decreased abundance of short-chain fatty acid producing bacteria, and you could relate the richness of the gut microbiome to some higher intestinal permeability and lower circulating plasma acetate, which is really the only short-chain fatty acid that we can pick up circulating in reasonable quantities. The progressors to type 1 diabetes, which I'll show in the next slide, had higher small gut intestinal permeability, with some caveats to it, which I'll show you. Lower gut microbiome richness shown here on the right, that's the blue in the progressors, and a low abundance of anti-inflammatory bacteria, as has been described in many cohorts now. What I did find interesting was we sort of hypothesized that we looked at their nutrition, and we hypothesized that their nutrition in the children with type 1 diabetes and autoimmunity might not have the influences that the healthy controls did, but found actually that both children with type 1 diabetes, autoimmunity, and the controls were affected by carbohydrate intake and fat intake in relation to plasma acetate levels, and indeed junk food related to reduced diversity in both groups. So I guess the dysbiosis is not interfering with the effect of potential nutritional intervention. And this is looking at blood lactose rhamnose levels, and on the left we have the finding, which has been shown many times really, that the intestinal permeability was higher in type 1 diabetes and sibling controls, and also in unrelated controls. So the recent onset type 1 diabetes children in the red and the controls in the blue. But on the right, we looked at the progressors. Now, the numbers are relatively small, and this probably explains the sort of strange fall of intestinal permeability in the progressors over time. These are the progressors from autoimmunity to stage 3, so to clinical diabetes, the non-progressors. So we haven't really explained that, and it wasn't explained by assay shift or anything. That probably is by the variability in intestinal permeability in the relatively small numbers, rather than a true finding. So turning now from the gut microbiome to the gut virome, and this is from Maria Craig and Bill Rawlinson's laboratory in University of New South Wales, and the work of Ki-Wook Kim, the postdoc on the left. And they also have been looking at in the pregnancies, comparing them with without type 1 diabetes. Left-hand column, you see the type 1 diabetes column, right, without type 1 diabetes. And there's some differences, as you'd anticipate, in the woman with type 1 diabetes. And in meta-analysis, looking at maternal virus infections, specifically maternal enterovirus IgM positivity during pregnancy in relation to risk of type 1 diabetes. Not many studies actually in this meta-analysis that had to be looked at, but showing a significant association between virus infection during pregnancy and childhood type 1 diabetes, odds ratio of 2.16, which was reviewed by this group as well. And a look at RND inference they've been using virome capture sequencing, which was pioneered really by Columbia University in New York, and of the first 630 infant stool specimens shows, not surprisingly, some differences with the TEDdy findings of the virome, and perhaps just emphasising again the importance of examining this in the Southern Hemisphere, and especially with discussions around potential vaccines for Coxsackie-B. It seems essential that we do look to see what strains are involved both from pregnancy into early life for development of autoimmunity relatively soon, and we are planning a first nested case control study before the final one, about which there's been some debate about that timing. That is going ahead. Now, COVID, as we've been saying, has affected everybody. We've been pretty lucky in Australia, and probably the main impact of the COVID pandemic potentially on adult immunity might be in relation to the effect of the social distancing on viral infections in Australia, because even though we've had relatively low numbers of COVID, we've certainly had a lot of changes to our lifestyle. And these are data which I'm sure you may well have US data that are similar really from some of our children's hospitals, showing these some dramatic changes in respiratory infections, in particular in children. This is for RSV bronchiolitis in the table with these dramatic reductions, which were really played out in all the children's hospitals around the country. And you can see in the bottom two figures, the really low rate of influenza A surveillance and respiratory symptoms in children in Australia compared with previously, sort of quite dramatic changes. And in fact, just anecdotally in our ENDIA infant diary, we've had these sorts of comments about children. So because there's some suggestion from Teddy that respiratory infections may be associated with developed adult immunity, certainly the respiratory virome over this period of time before COVID, during COVID and after will be very important to look at in these children, we think. Another Australian paper in relation to viruses, it was last year from the Murdoch in Melbourne. The lead author was Len Harrison, and they looked at the incidence of type 1 diabetes in Australia in preschool children 8 years before the introduction of the rotavirus vaccination and 8 years after, and showed this significant reduction up to 2007 just in the preschool children, not in the older children. And then shortly after that paper, one of the larger US insurers produced these survival curves with this reduction in relation to the full rotavirus vaccine program when it was delivered, which is very interesting, and it's whether we are actually having some primary prevention already. Perhaps explaining, certainly in Australia, we've had a flattening of incidence, particularly in the younger children, over the last 5 years. So now coming very much into some of the Florida pioneering work, and in relation to pancreas size, it was actually Martha Campbell-Thompson who suggested we look at these questions in our children. So realising we had very young children and wouldn't be able to do MRIs without anaesthetics, we've just used ultrasound. These are just in children presenting to our unit in South Australia with recent onset type 1 diabetes, comparison with controls. But just even with ultrasound, we could show significant differences, and in the orange are the recent onset type 1 diabetes children, and the blue children who came to our hospital for abdominal ultrasounds but had a normal abdominal ultrasound, and who are aged and gender matched. And then fecal elastase, while it was in the normal range, was significantly lower in the recent onset children with type 1 diabetes compared with controls. We didn't see a relationship like you have shown in your much, much larger cohorts and older children and young adults between exocrine function and area, not surprisingly, with these relatively small numbers. And of course, the area is not nearly as accurate as the volumes you're getting on your MRI work, but still interesting. So we had a look, admittedly early days with numbers, and these were children, the first progressors in India to adult immunity. We now have more like 57, but the first 28 progressors last year who were progressing with seroconversion around 1.5 years, so very young. And we did show a difference, but you can see from the lines on the top figures, there's a lot of movement in these children in their fecal elastase levels. We did a post hoc sensitivity analysis removing those two ones that had very high levels in the non-progressors, but we still showed this difference between the non-progressors and the progressors. So the non-progressors are gradually increasing their fecal elastase levels all over the first 2 years of life, and the progressors have blunted that rise. In fact, there's a fall over time. What was interesting was that there were I think there were 8 children who seemed to start their fall before seroconversion. There were another group that was sort of more around the time of seroconversion, and there were a group that seemed to be later as they're approaching type 1 diabetes, because of the 28 progressors, 11 had moved on to type 1 diabetes. So small numbers, but I think interesting. But the variability of fecal elastase and the normal rise in this age group, I think is going to make it a fairly difficult biomarker in these very young children. And continuous glucose monitoring, of course, we've got the TriNet data coming through and the WTT data coming through, but we're just looking at these very young children as well. We've all seen, I'm sure, these those of us who work with these children, these types of traces where it's very interesting where they're asymptomatic, still in stage 2 diabetes really, or moving through to stage 2 diabetes by the bottom graph, but this small amount of hypoglycemia occurring with this glucose variability before insulin therapy. It's very interesting to watch them. So in summary, just to sum off on the development origins before I move on to some of the other initiatives, we recognise this rapid increase is driven by the modern environment and children with low risk genes. We've got this robust predictor in early life. The omic technology is obviously revolutionised our investigations, and we're hoping the detailed follow-up will answer some questions in relation to early life influences and hopefully drive some primary intervention methods, realising the environmental influences are likely to be ubiquitous and act in combination, and some individualised prevention programs will be likely needed. So just moving on to some other screening initiatives that I've been involved with but haven't led in Australia. First, general population screening pilot. We haven't started general population screening yet in Australia, and we're interested in looking at some models to see what would be the best model for our country, and looking at obviously efficacy and cost effectiveness. But the most work thus far has been looking at these 3 possible models of 3 different cohorts in Australia as to how to screen best for feasibility and acceptability. And this work was done by, as the project manager was Dr. Kirsten Bell, who basically sort of started the project mid-March and hasn't really got back to Institute right through in Sydney, and was a good example of doing everything from home very effectively. And we are spreading the 3 different models across different states. So the first cohort will have 3,000 children having a genetic risk score on their newborn dry blood spot, which we do in the first 3 days of life in Australia. And the second cohort will have genetic screening using genetic risk score 2, which is 67 SNPs, in around 6 months of age in a saliva test. And then anticipating that 11.2% will have a score which will put them at a medium to high risk, and then they'll be followed with IgA antibodies measured on another dried blood spot at 1 year of age, and then followed up according to the results of that. Then the other cohort, which our state is involved in, will be just looking at autoimmunity screening using a dried blood spot in children aged 2 to 3 or 5 to 6. The capillary sampling kit will be sent to the parents, and they'll be suggested they take it to their pharmacists or primary caregivers if they need help, and then we'll provide follow-up according to that. This is going to, generate very, very low numbers of children who have autoimmunity, of course, but it's hopefully adequate numbers to test the acceptability and feasibility in the population as to which is the best method for Australia. Now, the Type 1 screen program, which was set up by John Wentworth, who I think you'll know, also head of the TrialNet consortium in Australia as well. This is an attempt to, with sort of minimal funding, set up a way for parents to be able to go to their local pathology laboratory and get screened with the central laboratory at the Royal Melbourne Hospital, was run by Peter Coleman, and then facilitate entry into stage 2, at stage 1 and stage 2 intervention trials. And we've brought some children into the hydroxychloroquine study this way, but primarily the children with hydroxychloroquine study have come through, some from ENDIA and some from TrialNet in Australia. And so it's children aged 2 to 30 years were brought in. And again, we set off in 2019, quite a rapid start, and then slowed things down a bit during COVID. Still kept going a bit, which was impressive. But it's crept up again now that we're doing better. Then just a little bit about so-called BANDIT, or the baricitinib.
It's Mark again, the interrupter. Can you go back a second? So, and again, I'm sorry for interrupting, but if I didn't...
It's probably easier.
No. If I didn't care, I wouldn't ask. So if you can go back one slide. Where you show the provinces.
Mm.
So as we move into so this is a relative of type 1 diabetes program, but as we move into notions of general population screening, is there something that you could tell us about these provinces that, is this match up essentially with population, or are there provinces that seem to be more receptive to participation?
I think it's a very good point, Mark, because in fact, I mean, we've been disappointed in South Australia because this wasn't something that we were really, obviously we weren't recruiting ourselves, as you say. This was something where they were given information about this program and could then really from their own local area get screened. And I think it's a good question, because these bands don't completely reflect population. So the example would be Queensland, which is green, has done rather well. And that is, it's a very good question, because we were just discussing that the other day, and my state's done relatively poorly per population, South Australia, and Western Australia hasn't done very well either. So it is a good question as to whether there's something about the community, and it certainly doesn't reflect the states which have had more activity in TrialNet either, and not at all actually. So it's a very good question, and we don't quite know the answer. They partly reflect population, but not entirely.
In part of it, I don't want to push things over time, and Mike or somebody else may have a comment, but you wonder, we've just heard for decades that if you have a really good study coordinator, you can make things rise. And if you don't have a good study coordinator in a state or region or whatever, things may not go good. So that's what I'm just wondering is,
no,
personality driven or population driven?
Well, I think it's probably because we didn't have a study coordinator for this, because it was basically sort of done somewhat without any funding really at all. And in fact, the only sort of engagement officer was this ENDIA engagement officer, and she sort of sits in South Australia, and she was sort of trying to, on the internet, reach out to as many families as possible that contacted her that way. So it was really very internet driven. And so it wasn't really anything to do with a local person. So back to baricitinib. So this is from St Vincent's Institute, is led by Tom Kay, who you'll know, the BANDIT clinical trial. And some of their background laboratory work, where they had been looking at the action of JAK inhibitors, Janus kinase inhibitors, to block cytokines and thereby sort of prevent expansion of CD8 T cells, as shown in this figure on the left. And then in their experimental models showing the JAK inhibitor was protecting from the development right through to type 1 diabetes. And the, oh dear, let's go. It's a very sensitive mouse here. So BANDIT, as it's called, is just starting recruitment now. The sites are across in Melbourne and my hospital. The primary objective is to see whether it preserves meal-stimulated C-peptide after 48 weeks of treatment with a 2-hour mixed meal. And then the secondary objectives, as listed there. We're also doing continuous glucose monitoring and the exploratory objectives to look at some immune mechanisms at the St Vincent's laboratory. And we're taking PBNCs from the children. So 83 children and young adults, 12 to 30 years, with recent onset, stage 3, randomized 2 to 1, one dose of baricitinib and daily. There's some evidence that when children are under 40 kilos, you need it twice daily, but we're unlikely to get many with that weight. And then the fairly close follow-up. We've got a sort of COVID plan if they have to be done more virtually or with home visits. So hopefully we won't have to do that. And then the primary endpoint at 48 weeks. And then the treatment ends at week 48. And then follow-up visits, 2 follow-up visits in the second year for the secondary endpoints. So we just started recruiting for that. And now just a little bit to our Australasian Diabetes Data Network. Medical director of that is actually Maria Craig. So we tend to have different hats for different things in Australia. Sort of same people coming back. So we're hoping that all children who have been in intervention trials who develop type 1 diabetes or have been in recent onset trials can be part of this network if at all possible. And it's also following about 40% of children and young adults in Australia and New Zealand with type 1 diabetes. We've centres sort of come on in dribs and drabs. We started off with the pediatric centres in Australia, then brought in some young adult centres as they sort of moved into those, and then brought in some centres from the pediatric centres in New Zealand. We have another pediatric centre in New Zealand coming in. And we were fortunate in Australia to get continuous glucose monitoring funded. It's just an example of real world study that we can look at and add in April 2017 for up to 21-year-olds after a lot of advocacy work, as you can imagine. This is not like present, but we've had a lot of prime ministers in Australia over the last 5 years. This is the second last one, Malcolm Turnbull, at the launch of the continuous glucose monitoring funding. And so we have potentially a lot of individuals in the network, data network, who were eligible under 21 years of age, and the uptake all over was 73%, and we could see, not surprisingly, the uptake in the younger children was higher, as we'd expect. And we've Tim Jones, who you may know from Western Australia, had the first look at, in 2018, the hemoglobin C levels of those who were and were not using continuous glucose monitoring. And there are obviously a lot of other covariates here which could be influencing this, but the first look is promising for improvement in hemoglobin C on CGM. So by CGM use, we meant greater than 75% of the time. And if we look at this, the odds ratios of getting a target hemoglobin A1C for these children and young adults, it's interesting, as the time goes on, that target started to become more frequently reached. And similarly, there was some reduction also in severe hypoglycemia and diabetic ketoacidosis in the children on CGM, although the numbers are still quite small, but they were significant. And just comparing the effect of continuous glucose monitoring on the pump versus multiple daily injection users, but seem to be helping both over time, although perhaps a little more with the multiple daily injection children. We have also shown in our unit, which was presented at the AGA this year, Jan Fairchild's work, that starting continuous glucose monitoring, being able to start it straight away after diagnosis, has been enormous help. We've just done our figures, and we have 78% of children 2 years after diagnosis still using CGM greater than 75% of the time, which is pretty good. So just to sort of sum up a little bit now, with not being a big country, we're hoping to really better get our framework across Australia and New Zealand more collaborative, so that the various initiatives can interact better. Certainly stage 1 and 2 screening and trials, we sort of can link here ENDIA, type 1 screen, and the general population screening pilot, which hopefully will become general population screening, and ongoing activities with TrialNet. We just have the 1 stage 3 trial at the moment, Bandit, but look at increasing that. As I said, our engagement officer for ENDIA is also doing the engagement work for type 1 screen, and is going to do some engagement work for the immunotherapy network that we're setting up, which is good to sort of keep some of those consistencies. And we're working through the data management for the database is also run by the University of Melbourne, as it is also for ENDIA, and also probably for Bandit. So we're trying to sort of coordinate our framework as much as possible. Thank you very much.
Thank you so much, Jenny. There's a tour de force of so much material. So I've got a number of questions, and I'll jump in, but then ask anybody else who's on to ask as well. So first, obviously our group is very interested in the pancreatic volume story, as well as the fecal elastase as a potential measure of exocrine function. So 2 questions. Have you guys had any experience in trying to collect stool samples in older children from ENDIA, or just really the youngest kids? And then 2, we tried to use ultrasound as well, and found that our radiologists couldn't get a good enough view to get consistency. So I've always been curious how you guys, because initially I thought that would be such a wonderful modality because it's so much cheaper and easier and non-invasive. Not that MRI is hard, but certainly cheaper to ultrasound. So could you speak to those 2 issues first?
Sure. So thanks, Mike. So the first, the stool samples for the older children, we are collecting stool samples obviously for the microbiome. And so I guess acceptability starts to fall a bit, certainly from about 4 to 5 years of age, it seems. I don't know if Australian children are different than US children, but it gets very difficult in teenage years, not surprisingly. But of course, our children are pretty young still. We have some over 5, but the median age is about 3. So we probably haven't really tested that yet, but we are we start to fall off a bit from about 4 years of age in acceptability, but we're sort of very much hoping to get at least 2 stool samples a year, 3 to 5 years of age. We don't have any funding at present to do more than IELTS autoimmunity and celiac autoimmunity screening after 5 years of age, but we do have. We have continued on that a bit with COVID. We can manage to do that without funding, but we may not be able to collect samples after 5 years of age due to funding restraints. In relation to the ultrasound, the ultrasounds were done by the one sonographer, Roger Gent, who's an AM, which is one of our honorary medals in Australia for his services to ultrasonographers. He's a bit of a legend, so I think he's as good as it gets with paediatric ultrasound, but I think too just having that one ultrasonographer probably made a big difference as well with consistency of approach.
Sure, that's helpful. Yeah, I was hopeful that we'd be able to translate that to multiple centers, but we haven't been able to yet. That doesn't mean it doesn't have a lot of potential. There's clearly a lot of story there in the size of the pancreas and the exocrine function as well. So shifting gears, I had another question related to the screening programs that you guys have been working on. Obviously, I think we're about to enter this era where general population screening becomes much more feasible, if not even demanded by some when we have therapies. And I noticed in your flow diagram, it seemed like you were referring folks once they were antibody positive to a peds endo. And I wonder if you could speak to the costs versus the potential logistics of sending folks that are stage 1 or even early stage 2 to general peds for follow-up versus a subspecialist.
Yeah, I think
it's something we're going to have to work out.
I think it's a really good question, and I'm sure it will possibly eventuate to that. I mean, at the moment, most recent onset type 1 diabetes is managed by Pediatric Endocrinology in Australia, as you probably know, where we have a sort of system where we have these sort of relatively large cities, and then we all do outreach clinics. But there are some general pediatricians with an interest in type 1 diabetes, and they do very well, you know, and I think we're sort of increasingly realizing that with a very good diabetes educator, you often, it seems to almost be more important than us, I'm afraid, once the technology's got going. And certainly in our state, if we look at how well children are doing, it seems to relate more to the diabetes educators and their presence in different parts of the state than us in our outreach clinics. But I think increasingly, we're very, certainly, I don't know about US, but certainly in Australia, this is an area which is considered rather new, and there's not much confidence in this area yet, but I'm sure it will come. I mean, we wrote an article about this for the Medical Journal of Australia, and we had to call it Controversies in Medicine, which sort of amused us slightly. Didn't see it, but so I think that will definitely come. And I'm sure you're right that you know, the idea of them all going to a pediatric endocrinologist with very early stage 1 diabetes is probably not appropriate. More if they were going to a trial, they would be referred across at that point.
Great. And then I'll just pause for a second. Somebody else has got a question, jump in. Otherwise, I'm going to keep asking. All right. So obviously another area very near and dear to my heart is immunotherapy trials during this period of COVID and even afterwards. I wonder if, obviously Australia's had a very different exposure. What is the feel there in terms of the ability to move forward with clinical trials using immunomodulating drug?
Well,
How do you think it's going to change?
As I said, we've just been able to start now, but it's only just this month that Victoria, Melbourne, where they had a second wave, which was seen very small to you, but they got up to sort of 800 a day, which was big for us. But they certainly had a very strict lockdown. I think it was sort of stage 4, or whatever the different lockdown stages are called, where most had to work from home, and all new trials weren't allowed except for COVID trials. So it's only now, and I mean, I've just been recruiting some people this week and talking to them about it, and one of the first questions parents ask, because we see giving vaccinations while on baricitinib probably is unwise, and a lot of people are asking, what about the COVID vaccine? But I don't think this age group will be getting the COVID vaccine in 2021. But I guess we do have a COVID sort of mitigation strategy if second waves came to one of our states, or a third wave in Victoria. And that would be, at the moment, to the visits that weren't having mixed meals to be doing entirely via telehealth, which we use clinically for a few months earlier in the year, and do that entirely by telehealth, and then have a local pathology. But the mixed meals possibly could be done at home, but we haven't done that yet. So I think we'd be stuck if we couldn't see them for those mixed meals at our facility.
Yeah, I'm always struck by just the difference of philosophy between different places on this globe. Your 800 a day is dwarfed by what we're experiencing here. And even though we definitely shut down the majority of our immunotherapy studies, in March and April, many of them are back on. But even there, it depends entirely on what's allowed in different states or regions, and sometimes not entirely based on sort of an objective measure of how much COVID is there. But I think the risk-benefit discussions between families and docs is always very interesting, because a lot of people have very different views, which are all reasonable.
I think it's a very interesting point, Margaret. I certainly, one thing that did struck me when we were doing telehealth was families were really very frightened. And even though in South Australia, we didn't, our first wave was really some international travellers, and I think it got up to about a maximum of about sort of 60 a day or something. We've had about, 600 odd cases total. So it's a really very small, we've still had, we had a temporary circuit breaker lockdown, and families have been frightened to come to the hospital. We still have to wear masks at our hospital. Families have to wear masks coming to the hospital. So the response has been very different. And I think it's interesting how fear has still been quite high in Australia, despite the fact that we've been so lucky relatively, and families have not wanted to come to the hospital for a trial.
Relative to that, have you seen, because we have seen, because certain subsets of people are more fearful than others, we've had some delayed onset or delayed diagnoses, and even unfortunately some deaths in the US from DKA.
Yes.
Who clearly didn't come to hospital because they were worried about exposure to COVID, missing the fact that they had new onset.
Yeah, some of the states have actually looked at that. It doesn't look as though we've had an effect on that, actually, and that's probably not surprising, given. But certainly emergency presentations reduced. But I think it was primarily because of respiratory infections being so reduced, rather than fear to come to emergency departments.
Hi, Jenny. This is Eric Triplett speaking. I can't get my video to work for some reason, so I apologize. Teddy is about to embark on SARS-CoV-2 antibody testing in its children with samples back from last February, thinking that SARS-CoV-2 infection might be a trigger for autoimmunity. I guess your infection rate in Australia is probably too low to test something like that.
Unless there are an awful lot of asymptomatic children we don't know about, and with our rates of testing being so high, and I think it's something like a 0.01% positivity rate, I think we're not going to be able to look at that. I think, Eric, we're going to be able to look at changes in the respiratory virome in relation to the social distancing that occurred, but
yes.
And they certainly will be looking for SARS-CoV-2 in the virome and in the work and in the Maria Craig and Bill Wilson's laboratory. But I don't think we're going to provide any information on that. But
that's a great idea, the virome social distancing thing, because that should decrease lots of infections, which should.
Yes, it has. Yes, it will. I think.
So
we can certainly look at that, and we can look at it, I guess, because we're much, much younger than Teddy, we can look at it in these sort of children at the time of IA seroconversion occurring, sort of before and after. So I think we can look at that, but not the direct effect at all.
Thank you. Great talk.
And we're a little bit past the hour. Any last questions from anybody in the gallery? Well, seeing none, I'll thank you again, Dr. Couper, for staying up late or getting up late and giving us this lovely talk. It's a real treat to be able to do this via telemedicine, Zoom, and hopefully we'll be able to do more of these across the globe, even after COVID, although it is always more fun to spend time with you in person. So thanks again. We really appreciate
Thanks,
it.
all the
Look forward to
best.
collaborating.
All the best to you all. Thanks.
All right,
Thanks so
take
much for
care.
the invitation, Mark. It was a pleasure. Thank you very much. Bye.
Bye-bye. Thanks everybody for joining us.